There are 7 drugs in the bare bones basic emergency drug kit, 2 injectable and 5 non-injectable drugs. This kit contains all of the drugs except for oxygen and several secondary items. The first drug, and the single most important drug in emergency medicine, is epinephrine, also known as adrenaline. Epinephrine must be available in an injectable form. I highly recommend a preloaded syringe such as the Twinject, which contains 2 adult doses of epinephrine in a 1 to 1,000 concentration. In the anaphylactic reaction, it is very common to use more than 1 dose. Depending upon speed of access to emergency medical care, it may be prudent to have 2 or more Twinject syringes in the emergency kit. Twinject is also available in a pediatric form for use in younger, lighter weight patients. The only indication for the use of epinephrine 1 to 1,000 is anaphylaxis, the life-threatening allergic reaction. There is no absolute contraindication to the administration of epinephrine in the anaphylactic reaction. In fact, persons who get epinephrine the fastest are more likely to survive. Those who don't get epinephrine or don't get it soon enough are less likely to survive. That's why epinephrine must be available in a preloaded syringe, and that's why there are no medical contraindications to the administration of this life-saving drug. The other injectable drug is a histamine blocker. Diphenhydramine, also known as Benadryl, is commonly included in emergency drug kits for the management of allergy. However, it is used primarily in the non-life-threatening allergic reaction. Histamine blockers are also used in the anaphylactic reaction after epinephrine has been administered. There are no contraindications to the administration of a histamine blocker during a medical emergency. Since there is no urgency in the administration of a histamine blocker, I do not recommend that this drug be available in a preloaded syringe. There is plenty of time for the doctor or the assistant to break open the ampule, load the syringe, and administer the histamine blocker. A non-injectable drug in our basic emergency kit is a vasodilator. In the dental office, a patient who has angina will bring their own vasodilator with them to the dental office. This is usually nitroglycerin in a sublingual tablet form. However, for the dental office, I strongly suggest nitrolingual spray for the emergency drug kit. It is as effective as a tablet, but it has a much longer shelf life. 1 metered translingual spray onto the patient's tongue is equivalent to 1 sublingual tablet. There are 2 contraindications to be aware of when administering nitroglycerin. One is a patient who is suffering from chest pain who is exhibiting signs and symptoms of low blood pressure. For example, they feel faint, lightheaded, or dizzy. A drop in blood pressure is a potential side effect of nitrate administration. Patients with anginal pain do not usually demonstrate a drop in blood pressure, whereas patients having an acute myocardial infarction commonly demonstrate significant drops in blood pressure. Another contraindication to the administration of nitroglycerin is the patient who has chest pain but has previously taken a vasodilator within the last 24 hours. Erectile dysfunction drugs such as sildenafil, which is Viagra, Cialis, or Levitra are vasodilators. If a patient takes nitroglycerin, which can lower the blood pressure, and has recently taken an ED drug which can also lower the blood pressure, this can lead to an exaggerated drop in blood pressure and to the loss of consciousness. Another non-injectable drug is the bronchodilator, used to treat bronchospasm or the acute asthmatic attack. The most commonly used bronchodilator in America is albuterol. 2 brand names of this drug are Ventolin and Proventil, and they are delivered in metered doses via an inhaler. Some patients, primarily children, may use a device known as a spacer to help increase the amount of the drug that they get into their lungs. After shaking the inhaler and placing it into their mouth, the patient breathes in, compresses the spray to inhale the medication. Usually within a matter of 30 seconds, maybe 1 minute, bronchospasm is relieved. Most often, the patient with asthma brings their own bronchodilator to the office and will use their inhaler, also called the rescue drug, at the onset of an episode of bronchospasm. However, there may be situations when an asthmatic patient doesn't bring their rescue drug or when somebody who doesn't have a history of asthma experiences bronchospasm for the first time, as may happen in some forms of anaphylaxis. So it's important to have a bronchodilator available in the emergency kit. The fifth emergency drug is sugar, which can easily be made available in a form of orange juice or a non-diet soft drink in the refrigerator. However, the refrigerated beverage may simply not be there when needed, so we recommend having a tube-dispensed form of sugar such as Instaglucose in the emergency kit. Hypoglycemia or low blood sugar is a relatively common emergency in the dental office and is easily managed if sugar is available. The sixth drug for the emergency kit is aspirin. Aspirin is a component of the pre-hospital management of suspected heart attack victims. One 325 milligram aspirin tablet, chewed and swallowed, is recommended for any patient who is suffering chest pain for the very first time. There are contraindications to the administration of aspirin. Allergy to aspirin is not uncommon and represents an absolute contraindication to its administration. There are no substitutes for aspirin in this situation. The last of our 7 basic emergency drugs is also the second most important drug in emergency medicine, oxygen. Oxygen must be available in an E-cylinder. The E-cylinder contains enough oxygen to ventilate a non-breathing adult for approximately 30 minutes. You must also have appropriate equipment to deliver the oxygen to the patient, and the cylinder should be checked on a regular basis and replaced if necessary. Another very important item in the bare bones basic kit is the AED, an automated external defibrillator. AEDs have been shown to dramatically increase the chance of survival in a sudden cardiac arrest and are now an integral part of basic life support for healthcare providers. The following is a demonstration of the AED. If you think someone has suffered a cardiac arrest, first check for response, shake and shout.
Are you okay?
If the victim does not respond, one rescuer is sent to activate the emergency response system and to get the AED. Another rescuer continues to implement the steps of basic life support, maintaining the airway, head tilt, chin lift. Next, check to see if the victim is breathing. If they are not breathing, give 2 quick breaths with a barrier device, such as a face mask, seeing the chest rise with each breath. Check for the carotid pulse. If you do not definitely feel one within 10 seconds, quickly remove the clothes from the front of the chest that will be in the way of chest compressions and the AED pads.
I'm going to start compressions when you turn the AED on.
Place the heel of your hand on the chest between the nipples, the mid-nipple line. Provide 30 chest compressions by pushing down on the sternum about 1.5 to 2 inches, allowing the sternum to rise fully to the original position before the next compression. Repeat the cycle of 2 breaths and 30 compressions 4 to 5 times for approximately 2 minutes before using the AED.
1, 2, 3, 4, 5. You go ahead and turn on the AED, please.
Some AEDs turn on when you lift the cover, while others have a power button. Open the pad package and peel off the plastic backing. Press the sticky sides onto the victim's bare chest, placing one pad on the upper right side of the bare chest to the right of the breastbone, with the other pad a few inches below the left armpit. Diagrams on the pads illustrate their proper positioning. Most AEDs begin to check the rhythm as soon as the pads are attached and connected.
No one should touch the patient.
If the AED finds a heart rhythm that can be treated with a shock, the AED will tell you so.
Stay clear of patient.
The AED will tell you when to push the shock button.
Shock delivered.
When the shock is delivered, the patient's muscles will jerk.
Emergency medical services
The AED will then tell you to start CPR, beginning with chest compressions.
CPR.
After 5 cycles of 30 compressions and 2 ventilations, pause for the AED to analyze the rhythm and then switch rescuer roles. Repeat the sequence of CPR and AED use until advanced life support providers take over or the victim begins to move. Keep in mind that if you are alone and find an unresponsive adult, you will have to activate the emergency response system and get the AED. In a situation where you're alone and find a child victim, give 5 cycles of CPR, then activate the emergency response system. However, if you're alone and witness a child collapse suddenly, activate the emergency response system and get the AED immediately. Then return to the victim to provide CPR and defibrillation as needed. The immediate implementation of basic life support gives the victim of sudden cardiac arrest the best chance of surviving. Time is the enemy. For every minute elapsing between the onset of cardiac arrest and the delivery of a shock, the likelihood of survival decreases by 10%. There are also a few secondary items for the emergency kit. The first of these items is ammonia, which is used in the management of a patient who is in the process of fainting or has fainted. The emergency kit should contain several ammonia vaporuls, but because fainting most often occurs during the administration of local anesthesia, 1 or 2 vaporuls should be taped to the wall or cabinet within arm's reach of the doctor or assistant in every treatment room. To use, the vaporul is crushed between the fingers and held under the nose of the fainting person, who on inhaling the noxious odor is stimulated to move, increasing their muscle movement and increasing blood flow to the victim's brain, provided they are properly positioned, supine. Another item is a mask to aid in ventilating a patient during rescue breathing with 16% oxygen. The pocket mask is a full face mask that comes collapsed in on itself. To use it, you simply uncollapse it and place it over the victim's mouth and nose. Holding the mask on properly, you then place your mouth onto the mask and deliver the ventilation. If a bag valve mask device or positive pressure oxygen cylinder is available, they may be attached to the pocket mask. There are 4 main categories that describe possible diagnoses: altered consciousness, respiratory distress, drug-related emergencies, and chest pain. They are based upon presenting clinical signs and symptoms. Signs are what the doctor can see, such as the patient who is sweating, a patient who is breathing rapidly, or a patient who might be shaking. Symptoms are those things the patient will tell you, such as, I don't feel good, I feel faint, or I can't breathe. In the first category, altered consciousness, we're dealing with the brain and alterations in its function. Examples of altered consciousness include syncope or fainting, hypoglycemia, and seizures. In the second category, respiratory distress, we have a patient whose chief complaint is difficulty breathing. 3 examples are hyperventilation, bronchospasm or the acute asthmatic attack, and airway obstruction. A third category is drug-related emergencies and includes the allergic reaction, both life-threatening and non-life-threatening, as well as drug overdose or toxic reaction to both local anesthetics and CNS depressant drugs. The final category is chest pain, in which we have a conscious person whose chief complaint is a vague pain in the area of their chest. This pain may be non-cardiac in origin, or it may be the result of what is today termed the acute coronary syndrome, or ACS. Examples are angina and the acute myocardial infarction. Cardiac arrest is a potential complication of ACS. Saving a life requires the implementation of a few simple steps, each of which is important, each of which must be carried out in the logical sequence presented earlier: positioning, airway, breathing, and circulation. As a healthcare provider, the dentist and members of the dental office staff should all be capable of implementing these steps as needed in an efficient manner. Once we have ensured that blood-containing oxygen is being delivered to the victim's brain, the PABC steps, a decision is made as to the diagnosis of the problem and to whether it can be managed effectively by the dentist in the office, as might be syncope, angina, or hypoglycemia, or whether outside medical assistance, 911, is required. This decision is made by the dentist. If any doubt exists as to the nature of the problem or as to its management, do not hesitate to seek help.